Hey Vasant,
Hi, Hi, Subra. How are you?
hi. Not bad.
Good evening, sir. Thank you so much for joining.
Hello, sir. Hi.
Hi, good evening, sir.
Apologies, I was on another recording. I just had to step out. Right. Hi Farah.
Hi, good evening, sir. How are you, sir?
Hey, life goes on. How are you?
All good, sir.
Okay.
We'll just wait for another minute, sir, and then we'll get started. First, we'll have the case presentation, then the talk by you, and then a discussion.
Okay.
So I think we'll get started at 7:35. There are quite a few people who have joined. So good evening, everyone, and welcome to the Society for Heart Failure and Transplants webinar on CMV in thoracic organ transplantation. This is a topic that continues to challenge us across the transplant journey, from prophylaxis strategies to management of complex resistant infections. And we're fortunate to have with us outstanding experts in transplant infectious diseases with us today to share their experience and insights. So it's my pleasure to introduce Dr. Y. Dayanandan. He's a consultant in infectious diseases and infection control at MGM Healthcare, Marar, Chennai, with a special interest in transplant infectious diseases and antimicrobial stewardship. And we have Dr. Subramaniam Swaminathan. He is really a legend in the field. He is Director of Infectious Diseases and Infection Control at Gleneagles Hospitals, Chennai and Bengaluru, and Vice President of the Clinical Infectious Diseases Society of India. And along with that, he has a number of other leadership roles, including including a member of the COVID task force for the Tamil Nadu government, a member of the mucormycosis task force for the Tamil Nadu government, co-chair of the India COVID guidelines, Vice President of Clinical Infectious Diseases Society of India, and he's had extensive work and publications in the field of infectious diseases, particularly in HIV and immunocompromised hosts. So with that, we'll get started with the case presentation by Dr. Dayanand.
Yes. I'll share my screen now. So my slides are visible?
Yes.
Yes, Daya.
On the outside, I'd like to thank the organizers and my teachers for this opportunity. We'll start with a case presentation. I'll be presenting a post-transplant patient, but it's a liver transplant patient, but principles of treatment and management of CMV remain the same mostly. So this is a 42-year-old male who'd been diagnosed with ethanol-related decompensated liver disease. He had his workup and vaccination done elsewhere, and he was positive for CMV IgG during his workup. He had no other comorbid illnesses. He was treated for pulmonary tuberculosis in 2012. He underwent a deceased donor liver transplant in 2019 March. The only induction agent used was methylprednisolone. His pre-operative and post-operative course was complicated by persistently low counts. He had pancytopenia with white cell count ranging from 1,000 to 1,500 even pre-operatively. It was assumed to be secondary to hypersplenism due to his DCLD. He had normal differentials. So preoperatively, a bone marrow examination was done, which was found to have a normal tri-lineage um, pattern, and post-operatively he was managed with tacrolimus, mycophenolate, and steroids. No prophylaxis were used since his counts were very low.
Yeah.
So on follow-up, he had worsening pancytopenia. So he underwent multiple transfusions, blood transfusions, in the month of September, around 5 months after transplant.
Happy birthday.
Shall I continue? Yeah. So he had worsening pancytopenia, for which he underwent multiple transfusions in the month of September in 2019. He was then admitted with fever, body pain, and lethargy primarily. And on further evaluation, he had poor counts in October of 2019. So his counts further dropped. The only other abnormality was his renal functions had worsened from a baseline of about 1.3 to a creatinine of 2.4 milligrams. So given that he's had fever, lethargy, and decreasing counts, they had performed a CMV PCR, which was detected to be more than 1,000 copies per microliter. So he was diagnosed as CMV infection and CMV syndrome, and he was started on IV ganciclovir, and his dosage was adjusted for the renal functions. He got about 200 milligrams per dose. So that's about 400 milligrams per day. So he at the end of 2 weeks of therapy, his fever still persisted. The counts were repeated, but it was even lower at about 600 to 1,000 per cubic millimeter. His hemoglobin was 4 and his platelet counts were about 45,000. He still felt feverish. He still felt weak and lethargic. At this point of time, an ID opinion was taken by the transplant people. So to sum up, this is a 42-year-old male with low counts pre and post-operatively. He underwent a DDLT, disease donor liver transplantation in 2019 March. He was not on any prophylaxis. He presents with fever and fatigue after 6 months of transplant with further drop in blood counts. On evaluation, his CMV viral load was high. He was initiated on modified dosage IV ganciclovir. And after the end of 2 weeks, there was no clinical improvement or lab improvement. So I'd just like to ask the panelists, what would be the natural next step? Would we repeat a CMV PCR, or should we stop the ganciclovir because his counts are even lower? It could be related to the drug or the disease. So do we look for newer problems now? Because he had a past history of TB. Is there a reactivation of TB causing a pancytopenia? Is there like a lymphoma, even though it's too early? Is there a GVHT or a HLH or a drug reaction because of ganciclovir? Or should we change to foscarnet?
That's a tough question, isn't it? I wonder if either Farah or Vasant would like to have a stab at it.
So this is a very typical scenario that we face normally in our day-to-day management of patients. Like when the CMV viral load is high, and then we start them on ganciclovir, and then the counts are even further reducing with no change in the CMV viral load. So at this point, the initial instinct is to just stop the ganciclovir because we cannot afford any more further bone marrow suppression. So this is what I would like to go for, to stop the ganciclovir. Another important thing would be to check for any resistance of the ganciclovir. That is what my outlook would be.
So I want to check with you how many weeks of ganciclovir he has received.
He was at the end of 2 weeks of therapy, sir, but doses were a little suboptimal because it was adjusted for the acute kidney injury. He had a recent rise in creatinine on routine evaluation, so the dosages that was started was lower than usual.
Yeah, so I understand that the induction dosage would be according to the creatinine clearance for first 2 weeks. So I believe that whatever the creatinine and creatinine clearance, and he must have received adequately the ganciclovir pertaining to that creatinine. So definitely I would like to know this. One is he is having a pancytopenia going on, and then there is a fever going on. So I would definitely like to know whether the CMV is responded to that or not. So I will definitely ask for the CMV viral load at this juncture to see whether my gancyclovir is working or not. Two is because of this pancytopenia going on, also I would like to see that the MMF is also one of the drugs. Has the MMF been stopped in this patient or it was continued?
Sir, until now it wasn't stopped. So there was no reduction in immunosuppression until this point of time.
So once you have a CMV, normally this MMF should be out because 6 months into transplant and it's a DDL10 liver usually tolerate transplant without immunosuppression also very well. So I don't think you require very strong immunosuppression there. So I think that MMF has to come out. But MMF itself is one of the another drugs which can cause a pancytopenia. Third is I would definitely look as other HLH what you mentioned, definitely look for that. And fourth is I would like to check for any other viruses like parvovirus also can cause a similar bone marrow suppression, but I don't want to have two viruses thinking of this. The first thing is I would like to check for the CMV viral load here, and I think if the CMV is active and if that is the reason why it is causing the CMV syndrome, whatever you want to say, because then I'll give Grafil, I'll give platelets, but you have to treat that CMV. That's very important. Another question would be to check whether you require to, if the CMV viral load is very high, at 2 weeks. I don't expect it to clear, but I would definitely expect at least 1 log reduction, and I would be happy with 1 log reduction. So that is what I would expect because at 2 weeks it's good. And if the patient is still symptomatic, then I would continue that and add if whether required to give a gamma globulin because transplant patients and with immunosuppressants on. So I think so many things require to be sorted before we really think about apart from new problems. I would look at new problems, but I think I would definitely go and look at the same CME whether we are able to control that or not. And I think apart from that, as I said, MMF, Parvo, HLH, and all that stuff.
Yes, sir. Thank you, sir. As the panelist mentioned, we had repeated a CMV PCR at this point when he came to us. So it showed a copies of more than 2 lakhs. There was increase in CMV copies, viral DNA from the last time. As bone marrow examination was done, again it showed a normal trilineage hematopoiesis. It did not show any new disease. It did not show any TB or anything like that. Neither there were any abnormal cells suggestive of CMV infiltration per se. And there was no evidence of drug toxicity also in the marrow study. There was no other evidence of other ongoing problem in him. And the creatinine was pretty stable. It was between 1.6 and 1.9. And there was no other specific organ involvement also at this point. So what would be the next steps, sir? So now that we have a marrow and we have a repeat CMV PCR, still this PCR is high. Do we ask for a resistance testing straight away because it's at the end of 2 weeks? He's still not responded. Do we change to Foscarnet? Do we increase the dose of ganciclovir or we just continue?
So one is I will optimize my immunosuppression. The first thing is I would optimize my immunosuppressions here because if you do not reduce your immunosuppressants, then your viremia is going to continue. So I think I'm going to look at that part. I may get rid of the MMF, reduce the tacrolimus by 50%, continue small dose of steroids at this juncture. Second is I think I would also maybe look at my dosage of ganciclovir, whether I'm giving it correctly for that creatinine or not. That is two. And third is possibly I know that creatinine is on the higher side, but I think in difficult to treat patients, I would think about giving even gamma globulin, even the common gamma globulin. Not if we because getting a CMV specific immunoglobulin is very very difficult. So you can just ask for a regular gamma globulin, which would equally work well. Now talking about drugs other than which causes resistance I'll definitely send it for resistance testing. But I'm not expecting resistance here unless this patient has been on Valgan prophylaxis in the first 3 months. If the patient has not been on Valgan prophylaxis, we don't expect a resistance to be here. So that will be possibly failure of treatment. Anyway, I would send it for resistance testing for looking for UL54 and UL97 for year, or even UL56. That is what we would look at. And phosphorinate is not easy because with a creatinine of 1.9, it's going to be a challenge, and is equally going to be CD4B is going to be a challenge here. So I think I will here at this juncture possibly optimize my immunosuppressants, significantly cut down, recheck my dosage of ganciclovir, what is going on. I would add a gamma globulin here, and maybe after 1 week of this, see whether we are able to reduce the viral load or not before even thinking of phosphorinate and CD4, and look at the resistance testing.
Yes, sir. So I'll just continue with the further course in the hospital. As Vasant sir had mentioned, the first step that we did was reduce his immunosuppression. We stopped the mycophenolate mofetil, and later tacrolimus dose was also reduced to about 75% initially. And ganciclovir dose was stepped up to 5 mg per kg 12th hourly. So even in Stanford, the usual induction dosages, even for acute renal or kidney disease, is 5 mg per kg 12th hourly is what is recommended. So after this treatment, his counts had improved to his usual numbers, which was present pre-transplant, to about 1,500 per cubic millimeter. And he had a symptomatic improvement as well. His fever settled down and his tiredness improved. The IV ganciclovir was continued until viral clearance for about 2 weeks, and he was doing well on follow-up, so we had stopped the treatment.
I remember with this patient because Daya had was with me during his training when we had actually seen the latter end of his care. It was a very weird kind of a situation, and something that helped us understand a lot of concept about CMV that we don't always talk about. So I'm going to, with the kind permission of the moderators, I'm going to take off now and give the spiel about CMV and how it affects solid organ transplant, and hopefully I can tie in some of the things that Daya brought out in this case with what I'm going to talk about.
Yes, sir. Please proceed.
Okay. Okay. Trust all of you can see this, right? So, CMV infection, where are we? Disclosures, that's important. So, when we talk about infections post-transplant, I mean, I know this about CMV, so I'll just quickly do this because I think it kind of feels incomplete if we don't talk about how we go about infections after transplant. So, start from before transplant, understand what the risks were before transplant. Baseline serologies, that's point number 3. That's where CMV serology comes in. Sometimes we don't have access to donor serology. In heart and lung, obviously, donor serology is not going to be available. So you're stuck with only the recipient serology, but even that is useful. And keep in mind that a lot of the timelines and the signs and symptoms are generalisms. Each patient is different, and their progress through their healthcare after transplant is individualized. So while there are general clues about how things happen, when it happens, and things like that, it's not a hard and fast rule. Generally, there is a huge link between immunosuppression and specific infection risk. And like Vasant beautifully pointed out, keep in mind that reducing immunosuppression sometimes is the X factor in bringing the infection under control. Prophylaxis is a key strategy that a lot of us use in preventing infections. I've included valacyclovir here because in the Western world, there are still some people who were using valacyclovir for a long time, but that's not a really good drug for CMV. The good drug for CMV is valganciclovir, and now there is more and more evidence for use of other drugs. We'll come to that. Obviously, there are prophylaxis that we use in heart and lung transplant. Cotrimoxazole is used in both heart and lung transplant, which will cover for a lot of things. Do we routinely give antifungals? That's a whole different kind of worms. I'm not going to go into that. So when you have a patient who comes in post-transplant with a illness, look at all these points before you jump to any conclusions. Get good samples, make sure there is multidisciplinary approach and work together in making a diagnosis and understanding all the issues around the patient, because it's not, generally speaking, you don't just treat one problem. This is a patient who may have diabetes, kidney disease, liver disease, and they have a transplant, and they are immunosuppressants and so many other things. So obviously, you'll have to juggle a lot of things. And keep in mind that these things are general guidelines. And just because somebody's been on prophylaxis does not mean it can happen. It cannot happen. It may be delayed. You may have delayed onset infections. And the one we are talking about today is cytomegalovirus. So when do we see this? Well, in the early period, we are talking mostly about nosocomial infections. The middle period is when you see these kind of immunomodulating illness, and CMV being a very, very classical infection that we see in transplant. And like in the Western world, they keep calling it the troll in transplant. So CMV, we know it is a herpes virus. It's a DNA virus. It is very, very, very common in the community. Most of us would have picked up this infection in childhood, and we remain latently infected, probably lifelong. And disease happens when there is reactivation of this virus. So for most people, it is reactivation of latent infection. In small amounts, there may be new infection from the donor, and even smaller amounts where it is a donor negative, recipient negative. I don't know if that even happens in India. It can be a new acquisition from the community. Obviously, infection is not the same as disease. All of us are latently infected. Now, who gets disease? So there are multiple factors. There are recipient factors. Older people, higher risk. Race does seem to make a difference. Comorbidities. If there's a second transplant, what is the indication for the transplant? Is there leukopenia like this patient? What about transplant factors? Is there a serostatus mismatch, meaning the donor is positive, recipient is negative? Certain HLA types, ischemia time, the amount of immunosuppression, experience of the center, post-transplant use of prophylaxis, immunosuppressive regimen, and of course, rejection episodes. All of this can determine if somebody can get CMV disease. CMV disease is of two types. There is syndrome and tissue invasive disease. You could have both. You could have one without the other. So generally speaking, the highest risk is in those who are donor positive, recipient negative. Almost all our patients are recipient positive. Therefore, we would call them intermediate risk. Now, the intensity of immunosuppression obviously matters. Using lymphocyte depletion would increase the risk of viral infections. So if you were using rituximab or rabbit thymocyte globulin and things like that, that may increase the risk of CMV. Use of mTOR inhibitors would also possibly contribute to that. Comorbidities do make a difference, and the other things we talked about. So when you have a patient, always look at it in context of what else is happening. And sometimes you have to infer from context. Now, serology, pre-transplant, we do IgG. But the donor serology, like I said, is often not available. There is no role for IgM testing. We should only be doing IgG testing. Very often you have indeterminate levels. When you have indeterminate levels, always classify them into the highest risk strategy. So when we talk about CMV and we want to prevent it, you have two options. You either have the prophylactic option or the preemptive option. Now, prophylactic definitely for patients who are high risk, donor positive, recipient negative. Now, intermediate risk, where the recipient is positive. For a long time, this used to be a moving target. Should it be prophylactic or preemptive? Now, more and more people are moving to prophylactic because preemptive carries a lot of problems associated with it. Not that it can't be done, but each one has its plus and minuses. Prophylactic has been shown in large RCTs to be effective. The issue is the cost of medicines. And in our country, fortunately, medication cost is not that high. Side effect definitely is a concern because with Valga and Cyclover, the cytopenias can be an issue, but most of our patients actually tolerate it quite well. Keep in mind that just because in prophylaxis, it does not mean breakthrough cannot happen. And of course, long-term prophylaxis can lead to resistance. Vasant just briefly mentioned about that. And there are reports of breakthrough resistant CMV in lung transplant recipients. In stem cell disease, this is always a problem. And of course, even after you use prophylaxis, after you stop the prophylaxis, some patients can have a rebound of CMV and have CMV disease later on. So the time frame of CMV may be changed. So we always said CMV generally happens in the first 3 months in the absence of prophylaxis. Now we are seeing later disease. And remember that this is an ubiquitous virus, and therefore you're likely to see this all over the place. Let us say somebody does a bronchoscopy and does a BAL, and somebody does some enthusiastic soul decides to do a CMV PCR in that. Low-level shedding is normal. It does not mean that they have CMV disease. You have to correlate it with what is happening. Yes, if you have a higher level, it usually is not a good thing. But just because you find CMV in the respiratory secretion does not mean that he has a CMV pneumonia in the absence of clinical symptoms. The manifestations, generally, it's the syndrome, which is quite common, about little more than half of them. Although tissue invasive disease does happen in a significant number of people. So how does it present? Usually it's a febrile illness with no localizing symptoms. It can involve different parts of the body. It can involve the lung, the gastrointestinal tract, starting from the mouth to the rectal canal. Hepatitis, the liver can be a problem, the kidney can be a problem, the retina can be a problem. It can also involve the nervous system. One major issue with this is that it can also increase the risk for other infections, like fungal infections or PTLD. I've seen TB flare up after CMV disease. We've seen gram-negative bacilli become a challenge. PTLD secondary to EBV reactivation. And there are people who have noticed HLH also being triggered by CMV. So obviously, it can have so many other things that happen. And the really scary thing is that it's bidirectional, in that if you have a patient being treated for rejection, their risk of CMV reactivation is higher. And if we have a patient who has a CMV reactivation, their risk of rejection is also higher. And what is really scary is that CMV flare is an independent marker of death because it has lots of long-term indirect effects, which are really, really bad. And this is another reason why more and more people are moving towards prophylaxis. If we have agents which are safe, and do not carry the drug resistance risk that we may end up causing by long-term use. So duration of therapy usually is not less than 3 to 4 weeks. Everybody seems to think that CMV treatment is 2 weeks. That is wrong. You have to recheck after 2 weeks to decide when to start. For CMV syndrome, where it is blood viremia, it is a median of 3 to 4 weeks. For certain disease, you may need to give longer, like lung. IV ganciclovir is the gold standard. For very restricted tissue disease, where the patient is rock stable and GI absorption is great and things like that, we may be able to get away with oral valganciclovir, although that's not routine. Foscarnet and Cidofovir are good options for ganciclovir-resistant CMV disease, but also we need to understand the mechanism by which resistance has happened. And like Vasant was talking about, immunoglobulins, CMV-IG or IVIG, which can be used with antivirals, especially for CMV pneumonitis. Outside of that, the role of it is unclear. Even for CMV pneumonitis, the data is not very high. So why do we worry about CMV disease? You can have severe disease, which by itself can be fatal, like pneumonia, or it can trigger a graft loss either because of the infection itself or because of rejection. So in which case you have to look at the 3 basic blocks of management, which would include the antivirals. Second, reduce the immunosuppression. And third, in case-to-case basis, you can think about giving them CMV-IG or IVIG. So you can have resolution, you can lose the graft, or most importantly, and very commonly, you could end up with complications like rejection, fungal infection, bacteremia, and PTLD. So we will come to the drugs. So there are lots of drugs now which are available or can be tried for CMV. This is a list. It doesn't mean that you should try each and every one of those. So let's go over these drugs one by one. Valganciclovir. The traditional dose for valganciclovir prophylaxis is 900 milligrams once daily. But in our country, most people use only 450 once daily. That is off-label. But there is enough user experience to show that even at 450 once daily, there is very good efficacy in preventing disease. For therapy, if you're using it for limited disease, 900 milligrams twice daily. have to worry about cytopenias. And of course, the option is, of course, it's so much easier to give it as a pill. Ganciclovir is the gold standard, 5 mg per kg Q12, but it has to be adjusted for renal function. And in our case, we readjusted the dose because the patient had acute renal failure, and the dosage protocols are all for chronic renal failure. And of course, cytopenias are a major problem. Up to 30% of patients can have severe cytopenias, which require help. But the problem is this is only available as intravenous use. Foscarnet, it's a pretty toxic drug. It's nephrotoxic. It works for the certain mutations related to ganciclovir therapy, and it's only available as IV. Cidofovir, the advantage with that is once weekly. You can get away with the intermittent dosing, but it's also tremendously kidney toxic. The newer drugs are maribavir. Maribavir is an orally available anti-CMV agent, which has a completely different mechanism of action. The problem with this is that there is a significant amount of neutropenia and also dysgeusia, meaning a taste issue. While these don't sound so terrible, people who have taken it do feel really terrible about it. Now, this is meant for oral use, and as of right now, it is meant for salvage. Problem is that when they tried it in patients who had failed other agents, some of them did respond to maribavir, although relapse rates after stopping maribavir were also significant. So it's not a perfect answer, but it's something that we could consider for patients for there are limited options. Letermovir is the new kid on the block, which is primarily indicated for prophylaxis, 480 milligrams once daily. It is reasonably well tolerated. It does not have any cross resistance with the existing class of antivirals. It is not a great drug for therapy because drug levels are not enough and you can quickly develop resistance as a concern. But for prophylaxis, it's a good drug. Side effects are vomiting, edema, and in about 3 to 4% of patients, atrial fibrillation can occur, and it's important to know this. It's available both as IV and oral, and more and more people have started using it. Ideally, initially was started in stem cell transplant use, but now in solid organ transplant also, use has started increasing. Brincidofovir came in with a lot of fanfare. It is an oral analog of cidofovir, lipid conjugated. It is available as an oral, well, it was meant to be available as an oral weekly therapy or twice weekly therapy. But the problem is it causes a lot of diarrhea. And in stem cell transplant recipients, it actually did not seem to make a difference. And there was a slight higher mortality in this group. Leflunomide is a rheumatology drug which was used for rheumatoid arthritis and other such situations, which has been repurposed for salvage use against CMV. And the idea is to switch your mycophenolate to leflunomide, and that gives you a very good option. So that does have anti-CMV activity. It also has other antiviral activity. So it is something that can be used as oral for salvage. But you should be aware of the skin rash and liver dysfunction problem. Artesunate has also been used anecdotally, but it is reportedly ineffective and it is not a very great drug. But people sometimes try the combination of artesunate with leflunomide. But keep in mind that these are all Hail Marys, not routine drugs. So you have to start with ganciclovir and then go down the protocol for variable. So how do you start prophylaxis? You start by day 10 and go on for about 100 days. You can give it longer if the recipient is negative or if it is lung transplant. Going beyond that, the value of it is a little iffy. If you are giving high-grade immunosuppression because of severe rejection, there could be a consideration for at least monitoring CMV. What is the role for CMV immunoglobulin? Not routinely used, but can be used as an adjunct in high-risk patients. Does it help? These are some older papers that looked at it. In heart transplants, at least, they looked at the role of CMV-IG, antivirals, both or neither. And what they showed was that both the immunoglobulin and the antiviral seem to have some benefit independently. Now, the numbers were very small to see whether they have additive benefit. So this is a little more detailed one on factors that affected mortality in patients with severe CMV disease. As you can see, the first line there. CMV immunoglobulin with antivirals versus no prophylaxis, there seemed to be some benefit. Would I routinely use CMV immunoglobulin? Probably not. But would I use it for selected patients who have severe disease and who are not amenable to other treatment options? Certainly, it's a consideration. And what has been shown is that the addition of immunoglobulin or the antiviral slows down time to death as compared to not doing anything. So therefore, this could have some benefit. It also slows down time to graftings. Again, these are not very powerful interventions in that it doesn't change the situation from between night and day kind of thing, but it does help to some extent. So that's one of the reasons why we stay away from preemptive for most of our patients. Why? Because every time a patient develops CMV disease, it causes a lot of heartache and scary situations like this. And it is very difficult to monitor because as long as the patient is right under your nose, you can keep ordering for weekly PCRs and keep one eye on them. But once they go back to their hometown and they realize that things are better, they may or may not follow through on all the instructions. And they can end up with a severe CMV flare, and you're wondering why you let it go to this level right from the beginning. And also keep in mind that the CMV PCR that is done changes from lab to lab. These are all home brews. So comparison between each of these may not be really easy. There's also a concern about what is the threshold. What is the number above which I would definitely treat CMV? Our patient had more than 1 lakh copies, so there's no question about it. But would I treat 1,000? Would I treat 5,000? Would I treat 7,000? Would I treat 3,000? Now, you'll have to define it for your own lab and your own patient population to try and figure out what the magic number is. Generally speaking, stem cell, we are more worried about the numbers. In solid organ, we may allow a slightly higher number, but then again, it all depends on the organ, the immunosuppression, and how the patient does. What is the risk of inducing rejection? That also needs to be considered. So what we are now seeing is late CMV disease because of prophylaxis and stopping therapy, and of course with rejections and whatnot. We are now seeing ganciclovir resistance, especially in lung transplant recipients, generally in the high-risk patients, but we do see it once in a while in non-high-risk patients. Problem is, testing for this is not routinely easy. You'd have to send it to a center of excellence to get it back. Treatment options are you can combine foscarnet with ganciclovir or go for one of the newer drugs if you can reach it, and go for immunoglobulin, and always look at reducing immunosuppression and playing with the immunosuppression. So, CNIs, calcineurin inhibitors, are some things which actually are used very commonly, things like tacrolimus and cyclosporin. As compared to that, mTOR inhibitors like sirolimus have a better protection against viral infections, and therefore switching them to one of the mTOR inhibitors could be an option, although it's not something that we do routinely because long-term outcomes with mTOR inhibitors seem to be poorer. Therefore, we still prefer a CNI, but if the virus is causing too much of a problem and you can't control it, then one option is to switch the CNI to an mTOR inhibitor. And keep in mind that there is no one-size-fits-all. While we say 2 to 3 weeks, it's not 2 to 3 weeks. Most patients require longer duration. And how do you know that? Well, if the viral load is very high at start, it's obviously going to take longer. If the viral load is coming down slower, it's going to take more time to get the virus fully under control. And of course, if there is virus still persistent at the end of therapy, that's a really, really bad sign. So what should you do? You should always get a baseline pre-treatment viral load. Monitor viral load. I usually do it only at the end of 2 weeks because the first week you don't change anything. And be ready for at least 3 weeks of therapy. Don't tell them it's 2 weeks. Be ready at least for 3 weeks of therapy. And quite a few of the patients may need longer duration of therapy. So to summarize this, know your serology pre-transplant. We prefer prophylaxis. CMV breakthrough can happen, especially in the patient, in some patients, and late disease is becoming a bigger problem. So CMV PCR is now measured quantitatively and reported in international units, basically for comparability between labs. So even if there is breakthrough disease, the drug of choice as of right now is still ganciclovir. Repeat it in 2 weeks' time and then take calls. If it is positive at 2 weeks, increase the dose, reduce the immunosuppression, and monitor the situation. If it is not coming under control, then probably add foscarnet and set for resistance testing. Always try and reduce immunosuppression. Monitor for newer problems that may happen. And also need to consider if the patient is a candidate for secondary prophylaxis once you have this under control. So our practice has been universal prophylaxis. We start valganciclovir 450 mg once daily, somewhere between day 7 day 10. And we continue it for 3 months and we monitor for toxicity. And at 450 milligrams once daily, it's almost unheard of to develop side effects due to that. And with that, I will stop.
So thank you so much to both the speakers for a really insightful and engaging case discussion followed by a talk. I apologize, I didn't introduce the moderators beforehand. So I'll just go ahead and introduce the moderators and they'll help answer some of the audience questions and also maybe lead the discussion with the speakers. So we have Dr. Vasant Nagvekar. He has completed postdoctoral fellowship in infectious diseases from the Tamil Nadu Dr. MGR Medical University, and he's the director of the Department of Infectious Diseases at Sir H.N. Reliance Hospitals, one of the most senior infectious diseases consultants in Maharashtra. And he's also a distinguished fellow of the Infectious Disease Society of America and mentor to many students in medicine and infectious diseases. And we have with us Dr. Farha Khan. She is she is infectious disease specialist working as a consultant at Narayana Hridyalaya. And we've had the pleasure of working closely on many cases, and I really value her clinical expertise. She has done fellowship training in infectious diseases from Hinduja Hospital with over 10 years of clinical experience in this field. So speakers and also answer the audience questions. Thank you so much.
I just wanted to request you that, I'm still, as a guest, can you make me the faculty so that I can answer the chat box?
Sir, I think you can go to the chat box and start typing out the answers, or if we can just, pick up the questions from the chat box and discuss it.
I can read the questions.
Yeah.
Okay. Patient with transplant, did we stop all his CMV treatment in 2 weeks? Did we give Valgan prophylaxis for some time? So, after treating CMV, first thing, 2 weeks, unless it's tissue disease, which is very limited, 2 weeks is usually insufficient. If you have CMV syndrome, most people will require longer than 2 weeks. Did we give Valgan prophylaxis for some time? In this patient, the patient that we discussed, we did give him Valgan prophylaxis, secondary prophylaxis for some time, because we had reduced the immunosuppression significantly and we had kept it that way. And we had talked to the primary team that we may chance rejection, but we will accept it and keep him safe. Should we routinely give secondary prophylaxis? Answer is no. He would go back on immunosuppression. Yes, once the CMV, CMV by itself is immunosuppressive. But once you control the CMV, you will need additional immunosuppression to keep the graft safe. Vasant, when do you start increasing your immunosuppression in the setting of CMV?
So I think first is once you stop the MMF, maybe after prednisolone and increasing the tacrolimus, possibly we may look at an alternative to MMF. If possible, we go in for it depends upon the concern, sirolimus or something of that sort, or everolimus, and then maybe after 2 to 4 weeks, then they would possibly relook at MMF. But provided 2 subsequent CMV viral loads have been negative, and after treatment for minimum of 6 weeks, I think it depends upon what is the CMV, your syndromic diagnosis. Are you dealing with a CMV pneumonitis or CMV liver, gut? Also important is every patient with CMV viremia, you have to do a fundus examination. I think that is a must, because if you have CMV retinitis, then your duration of treatment would be much longer than what we would give it in a normal person, because CMV retinitis, the treatment would be much longer, and you will require a prolonged immunosuppression in CMV patients who have got CMV retinitis. Subra, fantastic talk. I just wanted to check with you in all your liver patients, because we do in liver we do preemptive. we don't give prophylaxis here unless it is D positive or negative. So in liver, whereas in lung and heart, we usually use prophylaxis, and from nephro, I think it varies from the consultant. So what do you do in your center? Because in liver, we do a preemptive approach.
In liver, your organ is more forgiving in that even if you reduce the immunosuppression very rapidly, even with a mild rejection, you can recover graft function very, very quickly. Unfortunately, in lung and heart, the cascade going downwards, it's a spiral very, very quickly. And therefore, they are always more petrified about rejection. And they are very uncomfortable. The transplant physicians are very uncomfortable about reducing immunosuppression. So I'm very particular that we continue prophylaxis. In heart, 100 days more than enough, unless it's a specialized situation. But for lung, there is more and more consideration for longer term CMV prophylaxis.
One more discussion is if your CMV viral load, like the case presented, could you go from 5 milligram to 10 milligram per kg as a
Joshi, can you please mute everyone's mics other than the speaker?
Yeah. So the dosing of ganciclovir. So our patients are now not as small as they used to be. Many of our patients are actually quite sizable. And some of them have lots of tissue edema. They have a lot of other considerations. Because of which dosing becomes very, very complicated. So
Joshi, could you please mute the people who are not speaking, the people in the audience?
Yeah. Okay. Okay. So I always round up rather than round down. I think much is made of the toxicity of ganciclovir. And if it is cytopenia, we can always use GM-CSF and temporarily support them, and we can get them through. But I think we are often underdosing our GAN, and I think that's also leading to unnecessary problems. So would I go as far as 10 mg per kg twice daily? I don't know. I have never done that. But I would definitely not less than 5 mg per kg if you well.
No, so I think wanted to check with you. Suppose it's 5 mg per kg and your viral load is not getting suppressed, you have reduced your immunosuppression, and still the viral load is high, and creatinine is say 1.4, 1.5. You are given adequate of ganciclovir to the. So would you go in for meaning the question would be to consider gamma globulin, to consider increasing the dose of ganciclovir, considering foscarnet, cidofovir, depending on the. Of course, foscarnet would work for both 54 and 97. The broad range.
Correct.
Cidofovir will not work for UL 97.
Correct.
So correct. And nowadays mirabavir is somewhat available.
Correct.
So what would be your approach?
So I am not particularly enthused by maribavir because the data on it is not as robust as you'd like it to be. It's not really a knight in shining armor. If you look at the trial data and also the compassionate use data, it's okay. I mean, if you have nothing else, then yeah, maribavir could be an option. I think the 2 points that you already mentioned are worth repeating. First is try and see, can you switch to an mTOR inhibitor? I think the other trick that often people miss is leflunomide. Leflunomide is very, very powerful anti-CMV. There have been complicated CMV cases, even in stem cell transplant, which have not resolved with anything. But once we add leflunomide, it immediately cuts under control. The problem is because this will never get trialed, you're not going to see systematic data on this. This data goes back nearly 30 years from CMC. When they used it for kidney transplant. Unfortunately, this is not something that any company is happy to even look at or support, and therefore it's an orphan drug. So immunosuppression-wise, move to mTOR, add leflunomide. Now, as far as antiviral is concerned, push the envelope on the highest dose of ganciclovir possible and look at other complications. Is there a HLH? Is there other infections? Things like that. Then I would probably look at alternative agents. See, fortunately, drug resistance is not that common, and even if it does, foscarnet cytophover in most cases does have activity preserved. So for us to reach to Maribavir probably is unlikely. Keep in mind that there are compassionate use experiences even with letermovir for breakthrough infection where ganciclovir has failed. It's not a great drug for this, but as a Hail Mary, that could also be tried.
Right. So, any experience of CMV? Because we are planning to introduce, just like a TB Gold quantiferon, we're planning to introduce CMV quantiferon in HM Reliance.
Correct.
So, just wanted to, any experience? Are you using that in your?
Not yet. Not yet. It's a very, very interesting concept. And thank you for bringing that up. So the point is that it's our T cells which are required to activate to keep us safe from CMV. You need lymphocytes. Now, interferon gamma release assay specifically designed to look at CMV activity is something that is gaining ground. I think we need more data on this. The concept is that if the recipient has developed CMV specific lymphocytes which can generate interferon gamma, then it probably means that the chance of CMV breaking through is very, very low. How does it make a difference? In the Western world, at least in transplant, they're dividing patients into two groups. Those who are interferon gamma positive, the others who are interferon gamma negative. And the interferon gamma negative are the ones who are given additional care, additional medical therapy and things like that. The ones who are positive, we may not even consider secondary prophylaxis and things like that. Now, how will this play in the long term? I think I want to see a little more detail. But I think this is a very sensible and a very interesting way of looking at our own immunity to try and see how we can prognosticate and decide which medical avenue is a better fit for that person.
So another question always comes, we keep struggling whenever the patients are on renal replacement therapies and the dosing of ganciclovir, whether it's a regular HD, SLED, 8 hours, 12 hours, it becomes quite complicated. And I think we don't have ganciclovir levels with us. Otherwise, it would have been very easy because especially patients with renal replacement therapies on CRRT or whatever, it becomes a real challenge. Of course, CRRT becomes easier because you know the exact dosage, what to give. But then SLEDs of 6 to 12 hours, keeps varying every day, depending on the hemodynamic status of the patients. There it becomes really challenging.
I mean, the next frontier in this would also be adoptive T cell therapy. Now, that is still a little more in the future, but it's becoming more and more experimented on and available in the Western world. And that could also be an area where we need to look at. Obviously, this takes time and it's very, very expensive. But I think, 15 years ago, we didn't have that many options for CMV at all. And today we are talking about the futures of it, whether it's, using quantiferon gold-based analysis to look at how the patient is going to behave, and newer frontiers like adoptive T cell therapy. So I think the future is coming up faster than we anticipated.
That is CMV specific T cell therapy, right? I think
correct. We can educate the host T cells to activate itself so that it can fight the CMV and give it back to the host. So it's like basically taking the host T cells, put them in a lab, train them to fight CMV, make them the Shaktiman guys, give it back to the recipient, and then they will fix the problem for you. Sounds like science fiction, but we are almost there.
Yeah, and I think a few vaccines also seems to be promising, which are but still in trial. I wanted to ask you, what's your experience about patients who have ground glassing opacity post solid organ transplant, your PCR is negative, and your CMV viral load is significantly higher or equal to your CMV blood CMV viral load. So many times you see that your BAL CMV viral load is higher or equal to your blood CMV viral load. So I know there is not enough data
Yeah.
about BAL CMV
Cutoffs.
because there is
Yeah.
no cutoff,
Yeah.
and also no good robust studies about it. What's your comment on that? Because we do use CMV viral loads in the BAL many times because we are pushed against the wall. You have a classical CT features, PCP is negative, and all others negative.
So the good news is with multiplex PCRs, we are able to understand a lot of other respiratory viruses which cause problems. And in lung transplant, at least, what we call CARVs, the community-acquired respiratory viruses, are a major headache and a major bugbear. And thanks to multiplex PCR, whether it's metapneumovirus, whether it's parainfluenza virus, whether it's RSV, whether it's adeno, we're able to pick up all of those things. So we realize that there are a lot of other viruses which do have interaction and cause changes in the lung parenchyma. And of course, we should never forget our usual friends like pneumocystis. What do we do as far as CMV is concerned? Number one, if there is a pre-existing lung problem, let us say the patient has a bacterial pneumonia or the patient has PCP or whatever it is, CMV shedding is going to be higher at that point of time and does not by itself mean it's a separate infection. Second, you have to figure out what the cutoffs for your own level are. Third, generally CMV pneumonia is a very aggressive disease and it's not a tissue-only disease. They often tend to be blood disease as well. So I'd expect these patients to have very high levels of CMV in the blood. Number four, the lungs will start deteriorating fairly quickly because these are pneumonias which progress fairly rapidly and the patient is in big trouble unless you do superhuman things. Because he's the kind of patient where I would probably start looking at sourcing CMV IG if I can't, or if I can't get that IV IG to try and save the patient as quickly as possible. Do I have definite cutoffs in mind? Unfortunately, no. Fortunately, CMV pneumonia per se, so far at least, I think I've seen one possible case. So I've not had to deal with that so far.
So I think I'll hand over to Dr. Dayanandan and Farah for their comments and any thing. Dr. Farah and Dr. Dayanandan.
Yes, sir. Um, I think I've learned many new things today. The gamma interferon and the T cell therapy, I was never aware of it also. And thanks to Dr. Subra for enlightening us. There are a few questions which are there in the chat box. I'd like to go through them. One is, where in India CMV drug resistance testing is done? I'm not aware of it. Dr. Vasant, do you know, sir?
So I think in Mumbai, I think it's a Bangalore-based company, MedGenome, which is doing this CMV testing for 5497 and I think other markers also. So we have sent a couple of samples and fairly decent results. So
Yeah,
I think
MedGenome is doing it, yes.
is doing it from Bangalore. So they come and collect the samples and they give you the reports within 48 to 72 hours.
Okay. Thank you, sir, for the answering. And next is what is your take on letermovir on Indian setting as prophylaxis? I think we've discussed this question. Like letermovir is a very beautiful drug, and it has been
but
now
it's phenomenally wallet toxic.
Yes, and we have had the opportunity of using it in few of our patients when the time demanded, specifically in occasions where the sorry the blood counts were going low. So we had shifted to letermovir, and the results were very surprising and very eye-opening. Like we never used it before, and when we used it, we there was temptation for using it even more. Yes, and
that's what I've heard from my contacts in the Western world as well, and that's why most insurance companies in the US are not approving letermovir right off the bat.
Okay. So yes, we have had a couple of patients where we have used it and we have found beautiful results. So I think I can recommend other participants or other doctors also that we can go ahead and use it. And whenever the counts were normalized, we shifted back to our bulldog drug. So it was like a savior when the counts were low and the patient was sick, not due to CMV, obviously. We had used it. We never had the chance to use it when the CMV viremia was there, and I would not want to go that way because the literature also does not support that.
Correct.
We have other drugs to use when CMV
Agreed.
viremia is there. I have had few colleagues who have used it in CMV infection or letermovir. Their response was okay-ish and not so great. So
Yeah.
yes, this is something I might explore in future, using letermovir as a treatment modality for CMV. I hope I've answered your question.
Yeah. It's a Hail
Dr.
Mary.
Vishal. Yes. What is the turnaround time for drug-resistant testing? I think Dr. Vasant has answered like 24 to 48 hours. The next question is, sir, if post solid organ transplant patient with significant CMV viremia is not having any feature of colitis, any difference between choosing ganciclovir versus valganciclovir? So I think this depends upon the duration of which you have used ganciclovir. If you have completed 2 to 3 weeks and there is no features of colitis and the viremia level is going down and the patient is getting better, all the parameters are looking good. I think we can safely shift to valganciclovir. I would want Dr. Subra also to tell if this is the correct way.
No, that's fine. That's fine. If you're sure about oral absorption and and it is limited disease, oral Valgan is fine.
Okay. Because I think if we are sure of oral absorption and patient is getting better, we have completed 2 to 3 weeks of ganciclovir. Because beyond that, we are always skeptical of the ganciclovir showing its true face.
Right.
So when it will show the pancytopenia, we are very worried about that in transplant patients. So as soon as we can shift to Valgan is what we would want. So, no other question? Any advancement in CMV vaccine research? I think Sir has answered this question that research is ongoing. It is not there yet. So do you have any more information about the vaccine, sir?
Nothing the earth shattering. It's still in the molecular stages. It's still in the planning phases. They are looking at it as an adjunct, as an immunotherapy, but I think it's still very, very, very early.
So this is a very beautiful talk. Sorry to interrupt. And I got to learn a lot of new things. I would definitely incorporate in my own practice. And thank you for making me a part of it. Thanks, Dr. Aditi, and thanks, Dr. Nagarkar.
So I think, yeah.
Tala, you have anything to ask? Or?
No, I think, sir, the overall wonderful discussion, all the pertinent questions were answered. And I think I agree with Dr. Farah, lots of new things to learn, especially as a transplant cardiologist. Many new points that I picked up on. I took down some notes so we won't need to bother you as often, Dr. Nagarkar, with that silly questions.
So I think we can end this webinar for tonight. So thank you once again to all our excellent speakers and panelists for such a practical and insightful discussion on CMV and thoracic organ transplantation. And this discussion, I think, really highlighted the complexities of management and also the importance of balancing the infection risk, immunosuppression, graft outcomes, and the quality of life for the patient in transplant care. And thank you to everyone in the audience for participating. And on behalf of the society, my academic co-chair, Dr. Talha, the president, Dr. Jabir sir, and secretary, Dr. Manoj sir, we thank everyone for joining us this evening. And I hope this discussion was really useful to everyone in their day-to-day practice. And we look forward to seeing you again next month for our academic sessions. So thank you, everyone. Have a wonderful evening.
Thank you.
Thank you
so much.
Good night.
Thank you, everyone.
Bye, Subra. Bye, everyone.
Bye, sir.